Chapter 23, Cerebrovascular Accident. What is cerebrovascular accident or CVA? This is an interruption of blood flow to part of the brain. We already learned that the brain tissue needs that normal blood flow for it to actually receive that oxygen and for the organ to actually deliver its function properly. Without that normal blood flow, the tissue will have a deprivation of oxygen, and when there's a deprivation of oxygen, cell death will follow in as little as 4 minutes. Now, if we remember, parts of the brain are responsible for bodily functions. We learned that some parts of the brain are actually responsible for movement, balance, memory, thinking, language. Okay, so it really depends on what part of the brain is affected. So it varies. What symptoms are you going to see with your patient? It depends and it varies on the part of the brain, and it also varies on the length of time that the brain is actually deprived of oxygen. Obviously, you want it to catch it right away and you want to correct the issue right away, because if the blood flow is restored to the area that is deprived of oxygen in time, then the recovery of the brain tissue may occur. And with that being said, if we're not able to actually restore the blood flow to the area of the brain or the area that is affected, then there's a chance that permanent damage to the tissue, brain tissue, will actually occur. Okay, CVA is commonly referred to as stroke, or sometimes we even call it brain attack. This is the fifth leading cause of death and leading cause of adult disability in the United States. Good thing about stroke is if we do what we're supposed to do, then it is preventable, right? This is one of the most preventable of catastrophic events in the United States. You have the risk factors for your stroke, you have non-modifiable factors, and you have your modifiable factors. What are those non-modifiable factors? Those are the risk factors that cannot be changed, like your age, race, gender, and heredity. Stroke is more common in men, African Americans, people 51 to 74 years of age, and those with family history. Modifiable factors, please go to page 398 and let's go over these modifiable factors. These things are those that can be eliminated or can be controlled. That's why we call it modifiable factors. You have pathologic disorders that can be modified and can be controlled. And you have lifestyle factors. I'm in page 398, table 23.1. So for pathologic disorders, we have hypertension, cardiac disease, diabetes mellitus, and conditions that increases the risk for blood clotting, like for example, your sickle cell anemia. And on the right side right there, you're going to see some interventions that you can do to actually modify the effects of these risk factors. So read through this. Lifestyle factors, you have your excessive alcohol consumption, cigarette smoking, obesity, high-fat diet, drug abuse, and sedentary lifestyle. And then on the right side again, you're going to have the intervention to modify effects for risk factors. So read through this, understand it, and highlight some things, some important things. And while we're on this page, let's look over the signs of a stroke. Box 23.1 in page 398, you have sudden numbness or weakness of the face, arm, or leg, especially on one side of the body. Sudden confusion, trouble speaking or understanding, sudden trouble seeing in one eye or maybe even both eyes, sudden trouble walking, dizziness, loss of balance or coordination, sudden severe headache with no known cause. Most of the time, you're going to hear the patient tell you, this is the worst headache that I have ever had in my life. So if you hear that, that is a red flag, and you're actually going to start thinking about what are the other signs and symptoms of stroke and assess your patient. And hopefully, call the physician or call 911 for immediate transfer of your patient. Transient ischemic attack or TIA is a temporary neurologic deficit that is caused by impairment of cerebral blood flow. So yes, there will be an impairment of the blood flow to the brain, but this one is transient. Transient meaning temporary. What happens is that the blood vessels are occluded by maybe a spasm of the blood vessel itself or fragments of a plaque or maybe even blood clots. What is the difference? With your TIA, there's going to be a blockage to that blood flow, but it's temporary onset and without permanent damage. However, it's very important to remember that with TIA, this is actually a warning sign for a full-blown stroke. According to the book, 10 to 15% of patients that have TIA actually gets or have a stroke within 3 months, with half of this occurring within 48 hours. So even though this is temporary, it's still very important for the patient to actually go and get checked. Because again, the TIA can actually progress into a full-blown stroke really soon. What are common signs and symptoms of the TIA? Dizziness, momentary confusion, loss of speech, loss of balance, tinnitus, which is the ringing in the ears, visual disturbances, ptosis, dysarthria, dysphagia, drooping mouth, weakness, and tingling or numbness on one side of the body. And again, these signs and symptoms resolve with no permanent effects. So the nature and severity of these symptoms vary depending on the area of the brain that is actually involved and depending on the extent of the tissue that is deprived of the oxygen. How do we diagnose TIA? So we do MRI, which is the imaging that actually will show us if there's actually a blood blockage to the parts of the brain. Doppler, ultrasonic duplex, those are the ultrasounds of the blood vessels. So they're going to check and they can see the blood flow to the brain. CT scan, and then your EEG, which is the test that they do when we were talking about those seizure. It actually tests the electrical impulse of the brain. So medical treatment depends on the cause. Like I said earlier on, it could be caused by spasm of the blood vessel or a blood clot or the plaque. So it really depends on what is causing the TIA. After they do this imaging, after they do the medical diagnosis, then now they are going to give that medical treatment based on what is the case. So we can give patients aspirin, Plavix, Agrenox, Coumadin, heparin, Xarelto, and Pradaxa. So these are your blood thinners. What it does is, if you remember, these are actually helping the blood to thin a little bit and preventing for more clots to actually develop. And then they could actually have surgery, which is the carotid endarterectomy in page 402 if you want to see it. We call this CEA, or your carotid endarterectomy. What it does is, if you look at the picture in page 402, figure 23.1. So this is like an open surgery. This is invasive. They're going to open that neck, get into that carotid artery, and they're going to be removing that whatever it is that's blocking the blood flow. Obviously, if it's a plaque, right, or blood clot, then they're going to remove it. And the goal is to actually improve that blood flow to the brain. Let's go more in depth with stroke. Again, this is an abrupt impairment of brain function that results in a set of neurologic signs and symptoms caused by the impaired blood flow to the brain, and this one lasts more than 24 hours. There are two types or main classifications of stroke. One is hemorrhagic stroke, and the other is ischemic stroke. If you go to page 403, it's showing you a good picture of the difference between these main classifications. So in the picture right there, figure 23.2, the left upper one is a normal blood flow, or normal artery with normal blood flow. And then on the right side, you're going to see the hemorrhagic strokes. From the name itself, it's caused by bleeding. Okay, hemorrhagic strokes or bleeding are caused by cerebral arterial wall that ruptures. Okay, this is what we call hemorrhagic stroke. And then you have ischemic stroke. Ischemic stroke is either embolic or thrombotic stroke. So embolic are those caused by a dislodged thrombi, like emboli, that occlude or block those cerebral arteries. Where your thrombotic strokes, these are caused by those plaques that occlude that artery. So for your hemorrhagic stroke, the blood vessel ruptures, and then there's going to be bleeding into the brain. The ICP, or the intracranial pressure, will increase. Remember the three components of your increased ICP or your ICP: the brain tissue itself, the blood, right, or CSF. In this situation, the ICP is being increased because of the bleeding. This is sudden in onset and requires emergent life-sustaining treatment. So we have to be very careful. We have to be quick when we're dealing with hemorrhagic stroke. So it's further divided into classifications based on the location of the stroke. You have the intracerebral, which is within the cerebrum, and then you have subarachnoid, which is obviously between the arachnoid and the pia mater. Intracerebral, it's associated with trauma or uncontrolled hypertension or an aneurysm that bursts. Subarachnoid, this one is more of congenital malformations of the blood vessels in the brain and some rupture of an aneurysm. Ischemic stroke, like we said and we showed in picture figure 23.2, page 403. This one is caused by the obstruction of the blood vessels by either the plaque or the blood clot, or even a combination of two, or any debris that impedes the blood flow to the brain. What happens is that the brain cells um, is being deprived of the blood flow, being deprived of that oxygen, and then it starts to die and become ischemic, is what we call it. Put on your thinking cap. Why would patients with atrial fibrillations be treated with anticoagulants? Well, what is atrial fibrillation? Let's go back to cardiovascular system. Atrial fibrillation, or your AFib, is when the heart is not able to pump properly. The heart is just doing this weak and rapid and irregular beating. And what happens is that the blood is not flowing in a normal fashion, and it's just stagnant in there. So if you have that stagnant blood that is sitting in there in that heart, then the person is actually at risk, at high risk for blood clots. So that's why we treat them with anticoagulants, making sure that the blood is thin enough and decreasing the risk for blood clots. And why are we talking about this? Well, atrial fibrillation can cause blood clots, and we did talk about your TIA and your stroke that actually could be caused by a blood clot going to or traveling into the cerebral blood vessels, impeding that blood flow and causing that brain tissue oxygen deprivation or death. Signs of a stroke, we did went over it when we went over the table in page 398. The sudden numbness, sudden confusion, trouble seeing in one or both eyes, trouble walking, sudden severe headache. Like I said, your patient is going to tell you worst headache of my life. And then there's going to be stiff neck, loss of consciousness, vomiting, and even seizures. So how do we diagnose stroke? We do those scanning again, your CAT scan, your MRI, carotid ultrasound, cerebral and carotid angiography, your EEG, your PET scan, some blood draw or blood studies, EKG, because they're gonna see if your heart is actually creating that abnormal rhythm or abnormal rate, and then lumbar puncture. Obviously, what they're going to see is that your CSF is going to be like bloody, right? Instead of being that clear and colorless CSF, then the CSF in a lumbar puncture with patient that's on stroke, especially hemorrhagic stroke, they're going to see that there's going to be some blood in there. One thing to remember though is that lumbar puncture is contraindicated if increased ICP is suspected. So we did talk about increased ICP and what are the signs and symptoms of your increased ICP. If you're seeing those signs and symptoms, then as a nurse, it's your job to actually notify the primary care provider and notify the whole team that there's an increased ICP suspicion. So let's hold off on the lumbar puncture because we cannot do it. It's contraindicated if there's an increased ICP. So the medical diagnosis for stroke is very important because what they're gonna want to see is what type of stroke are we dealing with, right? Is it hemorrhagic? Is it ischemic stroke? So based on the diagnosis, that is when they're going to devise the medical treatment depending on what is causing it. If it's a hemorrhagic stroke, then obviously they're going to want to correct that bleeding. If it's a ischemic stroke, then obviously what they're going to want to do is remove that blood clot or whatever it is that's impeding the blood flow, and hopefully correct the situation, restoring that blood flow to that part of the brain that is actually affected. Complications of stroke. So again, this depends on the time and the extent of the damage to the brain tissue. Depends on the area, the part of the brain that is actually involved or affected. But complications could include severe motor impairment, constipation, dehydration, contractures, UTI, pressure injuries, and pneumonia, because obviously they might be um, bedbound at the time, or there's immobility. Prognosis, again, depends on the patient's condition before the stroke, because if it's a obviously if it's a healthy person and now experiencing stroke, there is a high chance that that person can go back to being that healthy individual again after the stroke. But if it's actually a patient that has been sick already, and there's a lot of comorbidities, there's a lot of disorders or diseases, then after the stroke there's a high chance that that patient will actually even decline from their baseline before the stroke. And then again, it depends on the length between the onset, diagnosis, and treatment. So, like I said, or I mentioned earlier, when we're dealing with cerebrovascular accident, time is very sensitive. It's very time sensitive. So that's why when you're a nurse that's taking care of a patient, for example, you're working in a long-term healthcare building, and you're taking care of patients. Obviously, you know these patients, you know their norm, you know how alert and oriented they are, and then all of a sudden you see that there's an increased confusion or sudden numbness or sudden weakness on one side of the face or the body. Then you're gonna want to act very quick. Time is sensitive, and the earlier that we correct the situation, then the less chance that that patient is going to have that brain damage. So the prognosis, like I said, it really depends on the time or the length between the onset of the symptoms, the time that it's diagnosed, and the time that it's corrected or treated. And then obviously it depends also on the severity of the symptoms. Like for example, if it's a hemorrhagic stroke and there's a lot of parts in the brain that is actually involved, then the symptoms will be more severe and the prognosis will be poor. Neurologic deficits that we will see after the stroke. These are terminologies that we need to remember. Aphasia, dysarthria, dysphagia, dyspraxia, hemiplegia, sensory impairment, unilateral neglect, homonymous hemianopsia, and elimination disturbances. So aphasia is a defect in the use of the language, speech, writing, word comprehension. So obviously the part of the brain that's responsible for this language and speech and writing and word comprehension is the one that's affected when the patient was having that stroke. Dysarthria is inability to speak clearly. Dysphagia is difficulty swallowing. Dyspraxia is a inability to initiate coordinated voluntary motor acts. And hemiplegia is a paralysis of one side. Unilateral neglect is when the patient is actually neglecting one part of their body. We'll go over that in a little bit. And then elimination disturbances, obviously, the involuntary acts are also involved. So page 404 is the right brain damage versus the left brain damage. That figure 23.3 you can see it. So the right brain damage, stroke is on the right side of the brain. Obviously, the paralysis will be on the left side of the body, or what we call hemiplegia, right? Paralysis of one side. And then the patient might have a left-sided neglect. There will be a spatial perceptual deficits or tends to deny or minimize problems. Rapid performance, short attention span, they might be impulsive, there will be safety problems, there will be impaired judgment and impaired time concepts. And this is for right brain damage. For left brain damage, the manifestation or the stroke is going to show on the right side of the body. Right side will be weak or paralyzed, or what we call again hemiplegia. There will be impaired speech, language, aphasia. There will be impaired right and left discrimination, impaired reasoning. Put it there, please add it. Impaired reasoning is for your left side of left brain damage. Slow performance, aware of deficits. There will be a depression or anxiety, and there will be impaired comprehension related to language and math. Let's go over table 23.3 in page 404, and I highly recommend for you to highlight this informations and remember them. These are the types of communication disorders after cerebrovascular accident. You have receptive aphasia and your expressive aphasia and your dysarthria. And what are the difference between the three? Receptive aphasia, the brain damage or brain lesion is actually in the Wernicke area of the brain. And what are the characteristics? These are those patients that are unable to comprehend or understand spoken or written words. So receptive aphasia is having trouble receiving what is being communicated to them. That's why it's called receptive aphasia. You're trying to talk to them, you're trying to communicate to the patient, but they're having trouble understanding or comprehending what you're trying to tell them. Expressive aphasia, from the word itself, is having some difficulty expressing or speaking or writing, right? Difficulty speaking or writing what it is that they're trying to communicate. They're having trouble to express it. That's why it's called expressive aphasia. The brain lesion is located in Broca area for your expressive aphasia. Dysarthria is characterized with a patient that speaks slowly with great effort. They're having so much trouble communicating. They speak slowly. And the words will be prolonged and then hard to understand. Okay, so please remember these three different terminologies that we need to remember when we're dealing with types of communication disorders after a cerebrovascular accident. All right, let's go back to the slide. Medical treatment in the acute phase. So you have phases of the stroke. You have acute phase and rehabilitation phase. Okay, acute phase and rehabilitation phase. With acute phase, this actually begins with the onset of signs and symptoms, and it continues until vital signs, particularly blood pressure and neurologic condition, stabilize. So if you are being asked in an exam and asking you, when does acute phase starts and when does it end? So this is your answer. Acute phase actually begins with the onset of signs and symptoms, and then it continues up until that patient's blood pressure and neurologic condition actually stabilize. From that moment, then that is going to be the rehabilitation phase of this stroke, okay? All right, some terminologies that we need to remember. You have stroke in evolution or a completed strokes, okay? Around this time, when the patient is in the acute phase, we need to monitor the patient very closely. What you don't want is for another stroke to actually happen, or more damage, right? More damage will cause more permanent um, damage to function of the body also. So stroke in evolution, the symptoms will progress over hours or days. And then you have what we call completed strokes, where the neurologic deficits do not change for 2 to 3 days. So, what are those major focus areas or those things that we're actually monitoring very closely during the acute phase? You have the hypertension, oxygenation, hyperthermia, and hyperglycemia. Please remember this four, okay? Major focus areas, again, hypertension, oxygenation, hyperthermia, and hyperglycemia. So, hypertension, we want to be very careful. Remember that when the patient had a stroke, then there's a decreased cerebral blood flow. So, when you're dealing with hypertension, we got to be careful with the sudden reductions of their blood pressure. Because if there's a sudden reduction in the blood pressure, then there's also a decreased perfusion of the cerebral tissues, right? If there is a decreased perfusion, then it may lead to a worsening brain tissue damage. And then hemorrhagic stroke. If you have a patient or taking care of a patient with hemorrhagic strokes, that's bleeding of the brain, right? And these are mostly caused by those uncontrolled hypertension, and the blood vessels become weak, it bursts, and it starts bleeding, causing a hemorrhagic stroke. So what you want is to prevent that from happening again. So that's why you gotta make sure that there's a good blood pressure control, so we can avoid the risk of more bleeding into the brain. Oxygenation, another important area that we need to focus on. Why? Because stroke is caused by that decreased cerebral blood flow and decreased oxygenation. So you don't want to worsen that, right? You want to make sure that there's enough oxygenation, there's a good oxygenation that is going into the brain tissue, preventing more damage into the brain tissue. Sorry, I got cut off from the previous slide, so we'll start with this slide, but we'll continue to talk about the acute phase and the things that we're monitoring during the acute phase. So hyperthermia and hyperglycemia. Hyperthermia, the fever is actually common after a stroke. So, but it's very important for us nurses to make sure that we're controlling fever, because obviously if there's an uncontrolled elevated temperature, then there's a high risk that you're gonna have that brain tissue damage, right? So how do we control it? You control it with those antipyretics like your acetaminophen or your Tylenol. Sometimes we would even use like cooling system or whatever it is that could help controlling the fever. All right, and then you have hyperglycemia. Usually, patient that just experience a stroke will have a increased blood glucose level. And the reason for this is, if we remember from MedSurg 1, when the body is under that stress or constant stress, and or the stress level is high, then the body is actually responding to it by secreting all those glucose. So that is the reason why patient that experience stroke will often have a hyperglycemia or elevated blood glucose level. However, obviously, if there's an uncontrolled blood sugar level too, it could contribute into further brain tissue damage. So how do we correct this? The current recommendations for treating hyperglycemia is using insulin, especially for those blood glucose that is more than 200 milligrams per DL. What we do as nurses is in the first 2 days, we monitor the blood glucose of the patient every 1 to 2 hours, especially those patients that receive those medication, which is called TPA. We'll go over it in a little bit. Um, we monitor their blood glucose every 1 to 2 hours to make sure that we are controlling hyperglycemia. And then every 6 hours in some patients, okay, that is more stable. All right, what are you on your thinking cap? I just answered this question. Why would a patient who had CVA may need insulin even without a diagnosis of diabetes? The answer is that they're at high risk for hyperglycemia because the body is under a high stress level when they are experiencing stroke. Therefore, we need to control it with insulin, making sure that we are addressing hyperglycemia or that elevated blood glucose. Medical treatment in the acute phase of stroke. We're still in the acute phase. What are those medications that we use during this phase? TPA is your tissue plasminogen activator, and this one must be initiated within 3 hours from the onset of stroke symptoms. And this is the reason why when you are taking care of a patient that has or experiencing a stroke, it's very vital for us to know as accurate as they can if they know when is the exact onset of the symptoms, because what you want to know is, are we still in the time frame of that 3 hours from the onset of the symptoms? Is the TPA that I'm going to give the patient going to be effective, right? What does TPA do? TPA is a medication that we use to dissolve clots. Okay, this is a medication that actually can dissolve clots. But remember, you have different types or classification of stroke. You have hemorrhagic and you have ischemic. So this one works for the ischemic because we're dissolving clots, right? So that's why it's very important for the patient to actually go through those diagnostic testing phase, which is they're going to do all those scanning, checking, making sure it's not hemorrhagic stroke before we even give this TPA. Okay. So those are the criteria that actually will meet for us to be able to give TPA, is that making sure it's not hemorrhagic stroke, it's actually an ischemic stroke. There is a clot that we need to dissolve, and it is within the 3 hours from the onset of the symptoms. Okay, other medications that we give, mannitol is one. It helps with decreasing the ICP, decreasing the edema of the brain. You have your nimatop to prevent cerebral blood vessel spasm, because again, one of the reason could be spasms of the blood vessels in addition to maybe hemorrhagic or the ischemic stroke. Dilantin or phenytoin and phenobarbital, those are your anti-seizure medications, because we are dealing with, increased ICP. And then you have aspirin, ticlopidin, Agranox, and clopidogrel, which are your blood thinners. Obviously, with this medication, what you don't want is to use it to patients that had a hemorrhagic stroke, right? So it really depends. The drug therapy or the medical treatment really depends on what is the classification of the stroke, what is causing the stroke. Okay, so that's why diagnostic testing is very important. However, while we're dealing all of those things, the time is very sensitive, so we got to be careful with the time also. Okay, page 400 is the medications for your CVA. Really important for us to be highlighting these things. Table 23.2, this is your medications for cerebrovascular accident. Highlight dexamethasone, which is your decadron. This one reduces ICP by reducing inflammation in the brain after the stroke. This is a steroids. It's an anti-inflammatory. But on the side effects, please highlight the last sentence. It says those usually tapered over 7 to 10 days to prevent acute withdrawal and adrenal insufficiency. Nursing intervention, please monitor INO, BP, blood glucose in people with diabetes, and protect infection because, again, you are giving steroids, making them at high risk for infection. So we are monitoring and protecting the patients from infection. Mannitol is your hyperosmotic agents. This induces diuresis, which reduces the intracranial pressure. We commonly use this for cerebrovascular accident. And then you have your anticoagulants, which is your heparin, enoxaparin, and warfarin. The most important thing to remember with these medications is they do not dissolve clots like your TPA, okay? They do not dissolve clots like the TPA. They prevent formation of new blood clots, okay? Again, if you encounter a question that is asking you what are the difference between the two, anticoagulants do not dissolve clots. TPA does, right? Tissue plasminogen does. Anticoagulants, it just prevents formation of new blood clots. It's just preventing for a new stroke to happen, or the stroke that we have or we're monitoring is actually, or treating, is actually not progressing into a worsening state. Okay, and then you have surgical intervention. Obviously, if there is a blood clot, we did talk about that carotid endarterectomy earlier on. That's one thing. Or they would even have to do like, it depends on what part of the brain is affected. They're going to do like a surgical intervention where they're going to have to go in and remove whatever it is that's blocking the blood flow to the brain. Fluids and nutrition, of course, very important. You don't want your patient to be dehydrated because, like we said earlier on, dehydration can also exacerbates the damage to the brain because of the decreased cerebral blood flow. And then urine elimination, not only urine, also bowel control. We're monitoring during the acute phase because some patients will have what we call incontinence, right? They might lose that ability to control that bowel or bladder. So we are monitoring them also for the urine elimination. And of course, monitoring INO. Okay, more interventions in the acute phase. Inadequate oxygenation. Obviously, like we said earlier on, you got to make sure that there's an adequate oxygenation. And what we do is we elevate the head of the bed 25 to 30 degrees, making sure that there's a patent airway. We're monitoring for increased ICP and addressing it right away once we see it. Checking the oral and nasal airway, making sure there's good hydration to thin the secretions, and deep breathing exercise because you don't want them to actually develop complications like pneumonia. However, please remember that if you are actually taking care of a patient that just had a stroke, forceful coughing is discouraged. Forceful coughing is discouraged. And why is that? I mean, we know that when you cough, there's like an increased pressure on your brain, right? Or on your face. Um, so we don't want that, especially if you have a patient that just had a hemorrhagic stroke, or maybe a patient that just went into surgery and came back, and you're monitoring them after that surgery. So you don't want forceful coughing. You want them to be doing the deep breathing exercise, but then discourage for forceful coughing. Okay, addressing potential injuries. So they're at high risk for seizure and fall. So you're gonna put your patients into seizure precautions and fall precautions. So what are things that we can do for seizure precautions, like padding the side rails or making sure the side rails are actually up, bed in lowest position, all of those seizure precautions that we can do for the patient to prevent injury. Fall precautions, like for example, making sure that the environment is not cluttered, making sure that the patient is actually using assistive devices that they need to be using for them to actually safely ambulate. And then there's a potential injury for what we call homonymous hemianopsia, or what we call unilateral neglect. Okay, let's focus on this one right here. Okay, unilateral neglect or your hemianopsia. What happens is that when the patient just had a stroke, there will be like affected side and the unaffected side, okay? And it's very important for us to remember and take note of this, because there's a difference when you're taking care of a patient during the acute phase and the rehabilitation phase. And we will talk about the rehabilitation phase later on. But right now, we are in the acute phase, okay? Acute phase, um, when there is a unilateral neglect, the patient's brain is registering it. For example, the affected side is on the right side. Right, so they cannot see anything on the right visual field. Okay, so they're only seeing, or they're only registering what is on the left side of their body. When you are taking care of a patient that is on the acute phase with a unilateral neglect or hemianopsia, you want to approach them on the unaffected side, because you don't want to spook them. You don't want to shock them. Remember that you are still in the acute phase. You're not trying to rehab the patient, okay? You're not trying to train anything. You're just taking care of the patient. You're trying to stabilize the patient. So you are going to approach the patient on the unaffected side, the side that is not affected, okay? So for example, they cannot see on the right side, okay? They can see on the left side. You're going to approach that patient on the left side, okay? So that she or he can see you, okay? Um, with the rehabilitation phase, it's different. We'll talk about that later on. But for now, acute phase, unilateral neglect, approach them on the unaffected side. All right, potential injury from sensory disturbance. Obviously, after the stroke, they might have disturbance in their senses. Like maybe they don't even feel that they're touching a very hot water already, and then they could burn themselves. Okay. Monitoring for hemorrhage, 24 to 36 hours, especially if the TPA was given, because remember, this medication is the one that dissolves clots. So we're actually putting the patient at risk for hemorrhage. So we are monitoring hemorrhage for 24 to 36 hours after the TPA is given. Cerebral edema is also common. So we are monitoring for increased ICP. And again, approach the patient in the unaffected side. You are in the acute phase, okay? Right. And then we are addressing also fluid volume imbalance. We're monitoring intake and output, vital signs changes, monitoring if there's an excess fluid volume, monitoring for fluid volume deficit, your dehydration, encouraging the fluids, and then place within sight and easy reach unaffected side. Okay, more interventions for the acute phase is addressing inadequate nutrition. Sometimes you will have patients that will now have impaired swallowing. They're going to have an inadequate nutrition, so you make sure that you address that. We can give them what we call a nasogastric tube, which is an NG tube that goes from, insert it in the nose, through the throat, and then going down to the stomach. And then you have your TPN, which are those nutrition that goes in the veins, in the big veins. Also, addressing elevated body temperature, like we said earlier on, you want to make sure that the patient is not having that uncontrolled um, elevated body temperature, because it could actually worsen the damage. So we give them antipyretics, like your acetaminophen. Potential for impaired cognition. So what you want to do is reorient the patient to surroundings. Um, want to make sure that we're introducing ourselves, explaining everything that is being done and why. Um, you would put like clocks and calendars as a reminders in the patient's room. Call light within reach, right? Reorienting them and telling them this is where things are. And just basically, making sure that the patient is aware of their surroundings. Okay, inability to communicate effectively. So there's things that we can do to make sure that we're still communicating effectively with the patient. These are things we can do. You can use brief, clear statements accompanied by gestures, maybe facial expressions, and maybe sometimes you might want to use like pictures. You gotta be creative on dealing with patients that are having those difficulty communicating effectively. You want to use close-ended questions, like something that the patient can actually answer with a nod of the head, or shaking the head no, or maybe they can answer yes or no. That's what you want, is a close-ended questions. You don't want for patient, this is the time where you're going to communicate to the patient, and you don't want them to elaborate like longer, right? Okay, and then be patient and give time for the patient to speak. Remember this arthria, right? Expressive aphasia, receptive aphasia, those three things that we did talk about when we're talking about types of communication disorders that happen when you're taking care of a patient that has a cerebrovascular accident. So be patient and give time for patient to speak, and they might even need to see the speech therapy for speech rehabilitation. And we just went over that page 404, table 23.3. These are the language centers of the brain. So again, when we did talk about CVA and your TIA and the cerebral blood flow blockage, I did mention that it really depends on what part of the brain is affected. So obviously, if the Wernicke area and the Broca area is affected, then you're going to have a patient that is manifesting those difficulty in communication. Okay, still in the acute phase, addressing impaired mobility. So they might be weak, and they will not be able to like move as stronger as they were before the stroke. So you got to make sure that you're checking the skin integrity, head to toe skin assessment, making sure there's no redness, there's no skin breakdown, repositioning them, right, very often every 2 hours, to make sure that there's no impaired skin integrity. Giving them those range of motion exercises to make sure we're preventing joint mobility problems. And then circulation. So you want to make sure that the blood flow is actually flowing properly. So again, range of motion and some, exercises can help. All right, urinary incontinence and difficulty voiding. Um, Most of the time, we will start with an indwelling or intermittent catheterization, because again, like I mentioned earlier on, they might have this incontinence episode because they have that impaired sensation and that impaired ability to control their bladder. So We might put them in an indwelling catheter or maybe an intermittent catheterization. And then after that, what we're gonna do is we want them to be on a regular toileting schedule, maybe checking on them often, checking if they're wet or they actually need to go to the bathroom or be toileted. We can actually use some bladder scanning too, checking if um, there's retained urine and it's time for us to be doing that catheterization. And sometimes we could even use like external catheters, like your condom catheters or PureWick or whatever it is. Constipation and loss of bowel control, same thing as your bladder control. You want to monitor and promote them bowel elimination, and maybe we need to modify environment. So like example is the high toilet seat. Because again, the main thing to remember during the acute phase is you're taking care of the patient, you're assisting the patient. However, you also want for them to be doing as much as they can, but don't force it, okay? Don't push it. Just help them and assist the patient to do as much as they can. And obviously, if they cannot do it, then we help and assist them doing it. Inadequate coping, because you're going to have patient that is actually going to be depressed and sad because not too long ago they're able to do things that independently, and now they are depending on someone to just go to the bathroom or maybe eat, or something that is a simple task or used to be a simple task for them. Now they're depending on somebody else. So this is um, a hard time for them. So make sure that we are actually addressing inadequate coping. Maybe have the social worker involved, maybe some therapists, psychotherapists. All right, and then altered family functions. So you might have patients that actually used to be the breadwinner of the family, and now they are depending on their family member just to be able to survive in a daily basis. So there will be altered family function. All right, now we're done with the acute phase. Okay, now we go into the rehabilitation phase. Rehabilitation phase starts when the patient actually reach that stable vital signs, stable neurologic status, and then there's no further neurologic deficits. Okay, the difference here is that in the rehabilitation phase, the goal is to maximize functional abilities and to teach the patient new ways to compensate for the losses. Okay, now this is the time where you're teaching the patient. Okay, all right. What you want during this phase is to actually train them to compensate for whatever it is that they used to do before. Now they have to adjust with what is the baseline for an everyday living, like your ADLs. Okay. One thing that I want to point out that we did mention earlier on in the acute phase is when you're taking care of a patient in the rehabilitation phase. Let's go back to my example earlier on. If the patient cannot see or is actually having that unilateral neglect, for example, the affected side is on the right side, right? They're not able to see or they're not able to move their right side, and then your left side or their left side is actually okay, and that's the unaffected side. During the rehabilitation phase, you're going to approach the patient, or you're going to put, for example, you're giving them food or you're giving them something, you want to approach them on the affected side. Okay, you want to approach or give whatever it is on the affected side. What you want for them is to actually scan that side. Okay, This is preventing further unilateral neglect. You're trying to train that brain. You're trying to train the brain to remember that there is the right side. Okay, there is another side. It's not just the left side that exists. Okay, there's a right side. So that's why we're doing that on the affected side, because what you want is to for the patient to actually, turn around and kind of like scan the whole area, so they don't have that further unilateral neglect. Okay. So in adequate self-care, you want to make sure that you allow the patients to try to do things for themselves. Do not discourage the patient. And again, making sure that they are doing as much as they can with ADLs. And then you have potential for injury. You are focusing for safety precautions, teaching them to call for assistance when assistance is needed, using their assistive devices when they are ambulating, and then adapting to their environment to promote safety. And then you have inability to communicate effectively. We continue to encourage communicating with the patient, or the patient to be communicating to us. But be patient, continue to be patient, because this aphasic stage, or the person or the patient may actually need more time to communicate. Inadequate nutrition, this is the time where the speech therapist and the dietitian will be involved, to make sure that they're addressing, maybe they can retrain for the swallowing, they can retrain on how to eat properly, and all of those things. And then impaired mobility, this is the time where physical therapy and occupational therapy are being involved, because what we want is to promote optimal return of motor function. And then for constipation, this is a common challenge in the rehabilitation phase. What we want is to put the patients in a regular bowel program, with toileting, reminding them, orientating them, making sure we're providing enough or sufficient fluids to promote the bowel regularity. And then for impaired urinary elimination and functional urinary incontinence, we monitor their urine output and then check for bladder distension until we stabilize a normal voiding pattern. Use the bladder scanner if we need to. Again, intermittent catheterization. Maybe this is the time also to train them, if they can do the intermittent catheterization. Okay, a lot of patients are able to do this intermittent catheterization by themselves. All we do is just making sure that we educate them, infection control, hand washing before and after if they can. Okay, and then providing them assistance as much as they need. Okay, and then bladder program should be initiated promptly during the rehabilitation phase. So what you want is to actually retrain them as much as we can. We want to retrain them, to be able to do the toileting. What we do is we're going to schedule toileting program based on the patient's usual pattern, and maybe hopefully we can actually control that incontinence. Okay, after the acute phase and then the rehabilitation phase, then the patient may be discharged to home or go to maybe a rehabilitation center for centers for continued therapy. There will be options with outpatient therapies like your PT and then OT. It's available. They can go home, discharged to home or some other rehabilitation centers, and then they will just continue with outpatient therapy. During and after the rehabilitation phase, Patients and families need to be made aware of resources to help them deal with continuing disabilities. And in rehabilitation, the patient is respectfully challenged to return to the highest level of function possible. Please highlight that last part, okay? All right, and that concludes chapter 23, Cerebrovascular Accident.